ok. Purtroppo dobbiamo andare avanti, Mark. You have a lot of questions because I'm seeing a lot of questions in my desktop. Anyway, unfortunately, we go ahead, and thank you very much. I should introduce Sage Myers. This Sage, I don't see in. Okay. Thanks for coming. I mean, virtual coming. Thank you very much, Sage. Okay.
Thank you. I'm going to start the presentation. I'm just going to pull up my slides. Can you see the slides?
Thank you. Do you have the presentation?
Yes. Can you see them?
No, I don't. I don't.
Okay, let me try one more thing.
No.
1 second.
Yeah.
Yes.
It says it is sharing. Can you see?
Yes.
All right, perfect. So
Okay.
hello, thank you for
Hi.
the opportunity to present. My name is Sage Myers. I'm a pediatric emergency medicine physician at Children's Hospital Philadelphia in the United States. Children's Hospital Philadelphia, or as we call it for short, CHOP, is a relatively large pediatric hospital. We see over 100,000 emergency department visits at our main campus each year, and we are a level 1 trauma center for our region. In addition to patients from Pennsylvania, which is our state, we regularly see patients from the surrounding states, including New Jersey and Delaware, which are close, and patients from farther away, both nationally and internationally. This is a schematic of our emergency department layout. Before COVID, this was how our patient flow worked. So we had one large mixed waiting room. We had 2 acute care teams, which existed in that triangle on the left, which have a total of 30 beds. We have a 3rd acute care team that specialized in respiratory care with 15 beds. We had an area that was primarily urgent care with another 12 beds, although it can be flexed up to see children with acute care during high volume. We had an observation unit with 14 beds to care for children needing usually less than 24 hours of ongoing care. We had 1 resuscitation room with 3 bed spaces, which was used for both trauma and medical resuscitations. Patients would move from the waiting room into all areas of the emergency department through a main hallway, which is designated by that red arrow. After COVID-19 hit, we did everything possible to separate patients with respiratory complaints from those without respiratory complaints. The patient sorting, which previously had been in the waiting room, was moved outside to allow for sorting of patients to occur before patients entered the waiting room. The waiting room was divided into an area for those with concern for symptoms of COVID, which is the green area, and those without concerning symptoms, which is the blue area. Patients with symptoms concerning for COVID enter the emergency department through a side door and are placed in rooms in one of the 2 green areas for suspected COVID patients. So they follow the orange arrows to get into the emergency department. Patients who do not have symptoms concerning for COVID enter the emergency department through our usual hallway and are placed in rooms in the blue triangle, and they follow the red arrows. A backup resuscitation room has been created for use when we have multiple resuscitations at once or when one is down for cleaning. We consider all resuscitation events, at least initially, to be possible aerosol generating procedures. And if they do include an aerosol generating procedure, then we have to hold the room down for decontamination. We were able to convert our main resuscitation room, which was initially normal pressure, was able to be converted to negative pressure. So it only needs to be down for 15 minutes for cleaning, but the backup room is not negative pressure, and it needs to be down for an hour if it is used. We also created a resuscitation command center to decrease the number of providers in the room, which I'll go over later in the presentation. We have created an emergency department COVID pathway. The pathway holds all of the information that we use to determine who counts as a suspected COVID patient, where they are cared for, and who gets tested, as well as everything that is involved in their clinical care. Given how rapidly things have been changing, this pathway changes very frequently, sometimes on a daily basis, and we really think about it as a living document. The main pathway and many of the attached documents can be accessed from outside at the link that's on this slide. Some links within the pathway that are contain CHOP-specific information may be behind the firewall and not accessible from the outside. This is the beginning of the pathway, which shows the arrival process. Patients arrive to the security desk at the entrance of the emergency department waiting room and are screened. They're given an ESI triage level, and the encounter is created in the medical record. Patients with cough or shortness of breath, with or without fever, are considered COVID suspected, and they're sent to the COVID suspected side of the emergency department, which is green. Those without those symptoms are sent to the other side of the waiting room and then on to the non-COVID teams. This is our new arrival area, which is outside the entrance to the emergency department waiting room. Patients arrive through the main door of the hospital, which brings them in the direction of where the red arrow is there. There they meet security registration personnel who direct them to the SORT nurse. The SORT nurse is always in a mask and eye protection, given their close contact with undifferentiated cases. And at that point, all patients and parents are given masks. This is the waiting room. The SORT nurse is out where that emergency sign is in the back. She's underneath that. Patients enter the waiting room at that door between the letters A and B. If they have symptoms concerning for COVID, they're sent to the A side of the waiting room on the left. If they do not have symptoms concerning for COVID, they're sent to the B side of the waiting room on the right. Respiratory symptoms are really what we are using to determine separation of patients. Although we recognize that patients without respiratory symptoms can be COVID positive, we also feel that these patients are much less likely to be spreading by droplet transmission. As I mentioned before, the patients with respiratory symptoms move out of the separate waiting rooms to separate parts of the emergency department. As far as personal protective equipment or PPE, staff are wearing surgical masks and eye protection for all non-respiratory patients. Initially, we were only in masks, but we had so many patients in that area that ended up testing positive for COVID that were then considered exposures for our staff that we moved to mask and eye protection at all times. For those patients who have respiratory symptoms and are placed in the COVID team, staff are wearing surgical masks and eye protection in addition to gowns and gloves for all patients. Patients who present with behavioral health concerns are also being treated as possible COVID suspected patients because we've had so many recently have been in inpatient psychiatric facilities, which have had outbreaks. In fact, anyone from an endemic area is also considered COVID suspected in the same way. The areas that are considered endemic change frequently and are screened for in our triage process. Now we'll move on quickly to testing. One quick note about PPE. Any patients that require aerosol generating procedures would be cared for in expanded PPE, which for us is either a PAPR with gown and gloves or an N95 with eye protection and gown and gloves. Importantly, we do not consider high flow nasal cannula to be an aerosol generating procedure, so this does not require expanded precautions. Now I'll move to testing. We have an in-house PCR testing that has an average turnaround of 5 hours. It's run a minimum of 4 times a day, so we still can have somewhat of a delay at times, but really the longest delay would be 11 hours. We have just started using rapid testing with a 1-hour turnaround with limited applications. This is the beginning of our testing strategy on the clinical pathway. You can see here, we test all patients who are being admitted to the hospital. For those patients who are stable to go home from the emergency department, we are not testing those who are asymptomatic, which means for us not meeting the current definition that we are using for suspected COVID, which is there on the left-hand side. So that would be patients with fever or sore throat or lower respiratory symptoms of cough, respiratory distress, tachypnea, or hypoxia. The only asymptomatic patients that are being tested at this time are those who live in a congregate living facility or those who have an upcoming aerosol generating procedure. For those patients who are symptomatic, any patients who have high-risk medical conditions or family members who are high risk or family members who are considered essential workers are all being tested. And also, like the asymptomatic patients, anyone who has been in a congregate living situation or behavioral health facility are being tested. And anyone who needs access to critical services like dialysis, where access could be affected by them having symptoms if it was not known that they were COVID negative. We have changed the way that we interface with families in many ways. We do not allow symptomatic caregivers, exposed caregivers, or positive caregivers in the hospital, and we only allow one caregiver with the patient. We do have a process for exemptions when needed for end-of-life care or situations where there's no alternate caregiver and the patient needs dictate caregiver presence. For any child with suspected COVID or any child or family member from an endemic region, the child and family cannot leave the room and they must be in a mask at all times. In general, we do not test adults. Occasionally it's done to allow symptomatic parents to be at the bedside with their child or for healthcare workers or other frontline providers. Our resuscitation plan has completely changed, as I alluded to earlier. We try to minimize the number of exposed staff members in the room. Everyone else reports to the command center. The command center has a live video audio feed streaming in, which includes the monitor screen and 3 views of the team. When we are intubating, one of the camera views is replaced by the CMAC video laryngoscope view. We communicate via headsets between members of the in-room team and those in the command center. The documenting nurse and the ordering clinician are in the command center. They do not go in the room. Any consultants report to the command center initially, and then a decision is made if they need to enter the room. All of the guidance and procedures for resuscitation are available to our clinicians through the pathway. And we have run multiple simulations to both test the new care model and practice its use. Now I'll go briefly into our clinical findings. So as of April 26th, we've had 196 patients that tested positive across all of our testing locations. So that includes outpatient drive-through testing. 79 of those patients were seen in the emergency department with a total of 82 separate emergency department visits. 53 of those ended in discharge from the emergency department. Our first ED positive was March 16th. We can see here an increase in positive tests by week. We definitely changed some of our testing criteria across that time. So some of that difference is due to who was tested, but this also mirrors our local activity in Philadelphia. Our mean age of those patients who tested positive was almost 9 years, but you can see that our age distribution is heavily weighted towards our youngest and oldest patients. So those less than 2 and 15 or greater. Of our total of 79 positive patients, less than half have had fever and just over 50% have had cough. Consistent with recent findings that have been discussed, 13 of our patients had headache. And interestingly, 16 had vomiting, which generally has not been discussed as a clinical criteria. Only 6 of our patients had sore throat and only 2 of our patients had any rash. 18 of our patients were what I would call unexpected or had no symptoms that would be suggestive of COVID-19 or had a clear alternate diagnosis. And I list those here. So 3 patients had suicidal ideation or intentional ingestion and 3 had aggression. Of those, many of them had recently been in a behavioral health facility. And our congregate living facilities near here, so places like juvenile detention, jail, rehab places, many of them have had outbreaks. We had one patient with chronic diarrhea who presented with diarrhea, one patient with a new diagnosis of epilepsy, one patient who had chronic headaches who presented with headache consistent with their past. We had a patient with sickle cell disease who presented with headache and ankle pain with no fever. We had a patient with a history of blebs and past spontaneous pneumothoraces who presented with a pneumothorax. We had two young infants, one that presented with vomiting and one that presented with abnormal movements that was determined to not be seizure. We had one patient with many medical problems with a history of feeding difficulty who presented with the same. And then we had a patient with a chronic mucocele, a chronic oral lesion that was diagnosed as mucocele, a testicular torsion, appendicitis, osteomyelitis, and then a patient with chronic lymphadenopathy. We've had 4 patients with severe illness. One of those that have come through the emergency department. We have had other patients in the ICU from other areas. We had a 4-year-old with a history of asthma who had an asthma exacerbation and required high flow nasal cannula. We had a 6-month-old previously healthy patient who presented with febrile status epilepticus. He required CPAP until his mental status improved, and he had a brief oxygen requirement after that. We had a 3-month-old unrepaired VSD who required high flow nasal cannula for increased work of breathing and some mild hypoxia relative to his baseline. And we had a 17-year-old with a history of severe brain injury from abuse who had many medical problems, who required initially BiPAP and then intubation with classic COVID ARDS requiring proning, who was still very sick. Overall, the PICU has had 5 COVID patients that required mechanical ventilation and 1 which required ECMO. We've had 4 that required vasopressor support and 1 death. We have used some treatments in those who are severely ill. We've used hydroxychloroquine 3 times, azithromycin once. We have offered remdesivir, but no patients have been placed on it. And we had 1 patient that was given convalescent plasma who was very, very ill, near having discussions about withdrawal of support, who got convalescent plasma and then turned around and now is much improved. Interestingly, we had 1 patient who was diagnosed with Kawasaki disease. This was a 5-year-old who presented with fever, abdominal pain, and vomiting. Initially evaluated for appendicitis, continued to have severe abdominal pain, had 2 ultrasounds that couldn't fully visualize the appendix, so eventually had an abdominal CT. The CT found no appendicitis, but the visualization of the lung bases showed ground glass opacities. The patient continued to have very high inflammatory markers and had some classic stigmata of Kawasaki disease develop, including rash. It was treated with IVIG, and that was their ultimate diagnosis. That's the end, and I definitely want to thank all of the people that are on our task force that have been working on this pretty much nonstop.
Okay, Sage.
Yes.
Thank you very much. We have 1 question.
Raffaele, I would like to do a question, if it's possible.
Go ahead, certo.
Okay,
Vai.
my question is, which is the sensitivity and specificity of your rapid test? And the second question, in your patient where you detect the virus, did you confirm the infection with antibodies? Because you know better than me that you can detect a small part of the virus, and that doesn't mean that this child is infected with COVID-19.
Yeah, so thank you for those questions. As far as the sensitivity and specificity, I think this is a problem that we all have been dealing with because there's no gold standard test that's being done. So we know that our test can detect a very small number of virus particles within a lab, but we do not know the sensitivity compared to a viral culture. So we don't know if you do a swab and you actually have COVID, is this swab going to be positive? We have had patients who have had, we just had a patient actually since this data who was initially an 8-year-old with no past medical history, who came in with sepsis-like syndrome, who improved, had a negative COVID test, went to the floor, was admitted, and then 2 days later had continued to be sick and deteriorated rapidly 2 days later with worsening sepsis, and had a positive test. So we don't know, was that original test a false negative, or was the patient very early in their illness when they presented originally and not positive? It's hard to know, but we definitely have had patients who were negative, who seemed like they had COVID by all symptoms, and patients who tested negative and then tested positive within the next few days. I think that we have no idea how to put a number on that. As far as treatment, we definitely treat anything that looks like a bacterial illness is treated as a bacterial illness with antibiotics as appropriate. We have had the one patient I talked about who got convalescent plasma, did have symptoms consistent with myocarditis, but also had a very significant past history of oncologic disease and chemotherapy that could also contribute to some myocardial dysfunction. Some people had asked before about neurologic symptoms. We have seen more than one child who presented with new onset seizures. One who I talked about as the febrile status epilepticus, and one who presented afebrile with new seizures, who were both COVID positive. It's hard to know what to do with that, but it does fit with the other stuff coming out of Europe reporting some neurosymptoms.
Ok, allora io direi siamo con un po' di ritardo, do la parola a Fabio per introdurre i 6 prossimi speakers.